Thank you. This should be a fun session, our first attempt at this office hours type of approach where it's your questions that we're focusing on. A lot of you gave up questions in advance. I did my best to put some graphics to that to explain them thoroughly and efficiently. So let's see how this works. We've got 15 questions that were presented. I think 2 to 3 minutes explaining it and 2 to 3 minutes perhaps of clarifying questions. We'll try to coalesce that at the end perhaps, see how that works out. As always, ask your questions anytime, and if it's going to pertain to your understanding at the minute, we will try to get to that right away. So here we go. So the first question, how do you anticipate managing data submission with a 4-phase in options for MIPS next year? Frankly, actually, this is updated now. The final rule is out, as you've heard. I've reviewed so far in depth the executive summary. We're still sorting through the 2,398 pages of the rule. So this table on the left changes a little bit, but overall, we don't anticipate any problem rising to the challenge. One will help you to understand the risk and benefit as usual. That's one of our strong points. When you engage, we help you understand the best strategy to approach as you approach the system. And then we'll add some routine processes. We're going to be training our staff so they know this system backwards and forwards. We'll be preparing client-facing documents to put in terms that you'll understand each of these elements of the program. We'll provide strategic guidance as we make those key decisions of how we'll progress through the program. And of course, there's 2 critical times to that guidance. First, when you engage us and say, how are we going to do this? So we'll have an answer for you. And in fact, I'm encouraged that Administrator Slavitt presented about a month ago his plan to pick your pace. And I think it does really give a way for every one of you to succeed. And so we're ready to help you choose those strategies to succeed. And then we will automate the rules so we know when we make a submission that it's accurate. We get the warnings when anything is out of sorts, and we'll review that with you at submission time to make sure we've got a submission that's good for you, and we'll adjust our analyzers to the new specifications. But generally, I think the great news is if you've already been quality reporting, there's really no big change in MIPS. You're going to be quality reporting in the same way you've always reported. There's a few new emphases and some details in the rules, like it'll be 6 measures instead of 9. But essentially, don't worry. If you've been succeeding with quality reporting, we'll take you to success in the MIPS program. Probably the biggest change is that no longer is just a qualifying submission enough with a non-zero performance rate. You're going to be judged on performance. So we're going to want to work early. So even though you have some ways to postpone being all into MIPS, 2017 Medicare is seeing as a transition year that you pick your pace. But my suggestion is don't pick such a slow pace that you're not working on measures throughout the year. We need to start working on the absolute level of performance so that once performance counts in the 2018 submission year, that you're going to rise higher in the list and perhaps into the incentive range. And in fact, things haven't changed so much that you can't be in the incentive range in 2017. So there are incentives to be earned, and we'd like to help you earn those. So some data, actually there's a 1 measure option that's a single measure in any of the categories, be it clinical practice improvement activities, quality reporting, or the basic 5 measures in advancing care information. Any one of those efforts you'll avoid the penalty. And you'll have a part year option that you can earn part of the incentive if you do a diminished submission, and there's a 90-day, and core measure, there's only a requirement for a 90-day data set to be all in the 2017 year. And yes, full in, we will be ready for it. We'll be ready to, we'll be turning our system around. So the moment we're done with 2016 submissions, we'll be ready to work with you on your 2017 MIPS data. We will have an entry form for you to enter your advancing care information. We'll have an entry form for your clinical practice improvement activities, and APMs, of course. Are you ready for that? I don't know how many of our clients are going to try to participate in APMs. We'll certainly be able to handle your reporting for that, whether it be qualified registry, qualified clinical data registry, web interface, any of those techniques. Monica asks, is the group measure one of the options in MIPS? Is the group measure? I'm assuming what you're asking is GPRO an option in MIPS? And yes, absolutely. Measure groups. It looks not. I didn't see it mentioned any. It of course was eliminated in the proposed rule. I've asked for it to come back in the responses. In the executive summary, it makes no mention of measure groups. So I'll see if I find it anywhere in the text of the final rule. I don't think it's there. But the interesting thing that is there is that they've reformatted those specialty measure groups. In the proposed rule, the specialty measures were just suggestions. Now they have some teeth. So if Medicare presents you with a specialty measure set that only has 4 measures in it, you get full credit for those 4 measures if you choose the specialty measure set. But it's still, unlike measure groups where if you don't have an EMR, you could do it, or if you do have an EMR and you don't have access to the data, the magic of the measures group is that you could do a 20-patient sample. There is no such 20-patient sample option in MIPS, at least not that I've found so far. I'll keep you updated. So next question, attribution. Our tax ID number is a multi-specialty surgical group. Am I to understand the patient is only attributed to our practice if they do not visit a PCP during the year? Any ideas to minimize patient attribution? Good question. So now a couple caveats before I get into that. One, Medicare's interpretation and application of this can change even in mid-season. And there's not always a match between what they publish as their intentions, their published protocols, and exactly how they implement it. But it does seem to be working just as you've described, and that's how it's written. That's the written protocol at the moment. So if there is at least one PCP, Medicare attributes the patient to the PCP with the highest number of visits, what they call the plurality of care. If there is no PCP, then they look to a specialist any specialist who bills any of the primary care codes, like the E&M codes, the office visits, 99212s, 213s, and so forth. There's about 25 codes, I think. I think we have a list on our website available too. And they attribute it to the specialists with the highest dollar volume of CPT codes that are considered primary care codes. So how can you minimize your attribution? Now, again, a caveat, it may not be practical and there may be offsetting losses. There could be backlash from patients or referring providers, but you could avoid attribution, one, by requiring a PCP visit prior to referral or in follow-up. So if you make sure that every patient has a PCP visit, then you're off the hook to be attributed. And second, if you don't bill primary care CPT codes, that all your codes are bundled codes or procedure codes, and you're just providing the pre-op and post-op care without applying a CPT code. And again, I don't know what you might lose in that transition. Then again, if you don't bill any of those primary care codes, you cannot be attributed to any patients. And I can't think of any other strategies to and any of you who have thought of any others, I welcome you adding it to the chat list or to the question list. I'll read them for the group. But those are the only two strategies I can think of that would work to keep you from being attributed patients. Next question, our tax ID number is a multi-specialty surgical group. We've been approached about the possibility of joining an ACO. Would you recommend joining? Will being a part of an ACO put more burden on our practice? So again, very good question. So the ACO considerations for a specialty practice, you need to understand the risks and benefits of belonging. And you've seen one ACO, you've seen one ACO. They're all a little bit different, and I can't really give you any specific guidance for the one you're considering. One question is, can or will it succeed? Do you really want to be part of it? Do you want to attach your horse to that particular wagon? Is it going to be able to cut costs enough to profit? Because you have to reduce cost of care if you're going to get any upside benefit and profit from the arrangement. And can the profits be sustained over multiple years? And that's another big question. The first question is generally answerable from inside the organization. Do they see those opportunities to cut costs so they can profit? But the second one is really the plan design. And so many plans are hungry to sustain savings and to increase savings over the years. They keep ratcheting you down. So what we're seeing in the ACO world is that there's a lot of churn. People get in, they might make a profit for a year or two, then they get ratcheted down and they can't keep cutting costs out of the system. They start losing money or not making any further profits, and then they bail. So now, I think the next observation is you don't need to belong. As a specialty practice, you don't need to belong to the ACO to serve the ACO. They need a complete solution because every ACO is trying to build a community solution to healthcare. And of course, every person needs access to a variety of services in the community, from primary care to specialty to tertiary to ancillary services, equipment, things like that. And your services are essential to making that work. You don't have to be a part of the ACO to contribute, but the ACO is going to want you, whether you are inside the ACO or affiliate or just providing services. They're going to want you to the extent that you help them cut costs out of the system and be efficient. And what I've observed over the market is cutting costs is really about planning care. When care is random, when it's unplanned, when there's a lot of duplication of tests, when there's not a clear plan of how you get from the primary care doctor to the specialist to the procedure and then recover, we find costs are much higher. When there's a plan and they tend to go to the same place time after time, it tends to be less expensive. So your being part of the care and participating is more important than actually belonging to the ACO. But the contract that they offer you is really going to tell you whether there's a benefit. Are they going to pay you better if you're inside than out? Are they going to be able to sustain those payments over the years? And basically that final bullets here, do they increase your worries or decrease your burden? And that's going to be if they increase your worries, don't belong. If they decrease your burden, by all means, get involved. Are they decreasing the difficulty of billing and collections? Are they reliable to handle your quality reporting? Because if you're part of the ACO becomes responsible for your quality reporting. And we've come across a lot of examples where they just don't rise to that challenge, and then you're stuck without a quality report and then losing money based on your inability, your failure to get data to Medicare. So let me just take a deep breath while you digest that a little bit. Then move on to, I understand that MIPS includes PQRS, meaningful use, and value-based modifier. So is meaningful use stage 3 rolled into MIPS, or is it still going to need to be reported separately? Oh, so, and here's my, so the answer is yes and yes. Meaningful use stage 3 is rolled into MIPS. It is now, under MIPS, it's called Advancing Care Information. It's been dramatically improved. The complexity has been removed from meaningful use. We're still moving on to stage 3, so the measures of stage 3 are, I think, and I'm qualifying this again because I haven't read the whole rule yet. We're just in the early stages of that. I do know that they've winnowed the 11 measures, which actually was a blended stage 2, stage 3 for the first year, or both options are there in the first year. For the 2018 year, you have to be on stage 3. But again, a dramatically different approach from before. Now there's 5 measures that serve as your base score. You have to present each of those measures, but all you need is a non-zero performance level. So if you have one instance where you've done where you've made the data transfer, where you've shared data, where you've whatever the measure is, you just have to have one that indicates that you have the capability to do it. And if you do each of those 5 measures, you get 50% of your meaningful use, or ACI, Advancing Care Information points. And then the rest of the 11 measures, all the 11 measures are available for advanced reporting. And you get the other half of your score is based on whichever measures you submit, and you don't have to submit all of them. There's more than 100 points, or a full points available for submitting those measures. You can't earn more than 100 points. So they will grade you on the performance across the organization. On those, your choice of the 11 measures that you send in. So again, it's going to be a lot easier. You also have a group practice reporting option under meaningful use. Again, meaningful use under MIPS is just one of 4 performance categories, and the score is blended with the other 4 or the other 3 to get your adjustment level. Medicare, it is a separate submission than your quality submission and your clinical practice improvement activity submission, but it should be done through, or Medicare encourages you to do it through the same vendor. And we will have an entry form that you can give your data to us, and we will give it to Medicare for advancing care information, and we'll make sure it's thorough. We'll help you with a strategy, which one should you go after, and those kinds of questions. So dramatically simplified requirements over the current meaningful use program. So I think if there's one thing that I'm delighted about in the final rule, it's the simplification of meaningful use. Medicare is still putting most of their pressure on EMR vendors to rise to the certification standards, and they're reducing the pressure on you to fully implement. They're letting you decide just how much EMR you're ready for, and to make some choices based on your needs and your patient's needs, your readiness and your practice, which elements of these are really going to help you. All right, next question. We are a gastroenterology practice who might want to report in 2016 via our EHR, but many of the gastro specialty measures aren't currently available for that reporting mechanism. Do you know if CMS will make changes to the way quality measures can be reported? All right, my answer is, so you're basically asking, should we report through our EHR? And I think the 63, the limitation to just 63 measures is a serious limitation of the EHR method for specialty practices. There are some specialty measures within the 63 measures, but they're very limited. And you're best served in the EHR if you are a primary care or general medicine practice. Also, remember that the EHR reporting has a very high failure rate. And I'll show you a slide on that from Medicare's experience report in a moment. And they tend to have and part of that relates to an inflexible one-size-fits-all approach. Their business model really demands that they've got to make their EMR applicable to a broad set of providers, and each of us, of course, is very opinionated on how the system should work. So they have to push you into a box that this is the way. If you use the EMR in this way, you'll get good results, and if you don't, you won't. And the feedback I get from clients is that creates the need for some fairly expensive and difficult training. You have to train your doctors to document in a single way to be able to meet the EHR approach. Whereas a vendor like us, we can cast a broader net. We can accept different extracts. We can look anywhere in the EMR where you're recording data and use that. Also, Medicare changes the rules dramatically every year, or changes the specifications. Now, a typical EMR takes about 2 years to bake a good new idea into their code, and another 2 years to get it out to their clientele. They really can't expand the rapid changes in the programs like a dedicated reporting vendor can. So those are some of the reasons for this high failure rate that we're seeing year after year in the EMR reporting. And also under MIPS, they really lose a lot of their competitive advantage. One of the things that's been pulling people to EHR reporting is that concept that a single report can meet your PQRS and your clinical quality measures needs. Well, that's no longer the case. Clinical quality measures disappear in the MIPS program. So you really just have one quality report, and any method can get that one quality report to Medicare. Plus, Medicare is introducing a bonus for an all electronic flow of data, and that bonus isn't restricted to the EHR method. That bonus is available to any method other than claims. And here I have a question from John that says, under MIPS, if you choose to report the quality category as a group, do you have to report the ACI category as a group as well? And the answer is yes. If you're a group for any one of the categories, you're a group for all of the categories. But again, don't be scared of that. I think I've always supported group practice reporting as the most cost-effective way of approaching quality. It's the same for everything. It's far better to report. It's a simpler process to report for a group. You're far more likely to succeed as a group in ACI and in CPIA. So, and you no longer have to declare yourself as a group by June the 30th, or at least that's my assumption. I'll have to read that for sure in the final rule, but that's what was proposed. So here, moving on that question, should I report EHR? And I think this is one of the defining slides. This is the most recent experience report out from Medicare. It's based on the 2014 reporting year. The experience report for 2015 will be published next April. And it shows just a 57% success rate for individual reporting under EHR. So if you care about the results, that's dismal. And for G-Pro EHR, the results were just 42% in 2014. As opposed to the registry, we see the individual measures, the measure groups, the group registry. Now, individual measures is at 59%. And, you know, I question that. I don't, well, for a good vendor, there's no excuse to be that low. So I think that underreports the potential our reporting in all three of those registry measures is hugging the 100% line in effectiveness. I think the EHR, in contrast, overstates their efficiency because most of the failures don't even make it to Medicare. There are some problems in the transmission. So I think this understates the failure rates for EHR reporting, and it overstates the theoretical failure rates or the vendor-specific failure rates for the registry measures. Oh, and part of that question is, will CMS make changes to the way quality measures can be reported? And the answer is yes. We've seen this doesn't change the dynamics of PQRS very much. Quality reporting under MIPS is going to be very familiar to you because you've been doing it under PQRS for a long time. And what we've seen is year by year, Medicare tweaks the measures. They support it in one method one year and change it to another, or broaden it or narrow it. Every year that changes. So a measure that wasn't an EHR measure this year might be next year. It might not be the year after. So keep watching for those changes. But and don't hesitate when the rules come out. And this would be a good time. With the final rule, there's also 60 days to make comment. I don't expect comments now to make much difference in the 2017 reporting year, but it will potentially affect the proposed rule and then the final rule for 2017. So if there's measures you want to see in the EHR measure set, put them into the comments. Yeah, so expect that annual evolution. There'll be new measures, there'll be retired measures, they'll change the specs on measures, they'll change the mechanisms they support for each measure. That annual change is just going to go on. And of course, that annual change is one of the reasons why EHRs don't tend to keep up with this as well as the dedicated reporting vendors. So next question, for 2016 PQRS for a GPRO, a group practice reporting option, is it best to only submit the 9 highest counting measures than submit all the measures a group is counting, even if a few of them are below benchmark? And I think it's clear, and it changes under MIPS, it's clear that it is best to stick with 9 and stick with your 9 highest counting measures. If you submit more than 9, Medicare will average those into your composite performance score. So it makes sense to have your 9 best. And the 10th is clearly the 10th best, and it's going to pull your average down. So now for most people, it's not going to make a difference because, as you may be aware, PQRS is a pass-fail system. So between the negative, PQRS is pass-fail. We're talking about value-based modifier when we're talking about the performance levels. Value-based modifier has cliffs. You're 0 until you get to 1 standard deviation above average, and then you fall up a cliff to a 1 or 2% gain in adjustment, or you hit a standard deviation below average and you fall off a cliff and you lose 1 or 2% depending on the size of your practice. So for most cases, it's not going to matter, but if you're at that juncture, a small change can throw you over the cliff. So clearly, you don't want to have more than nine measures in your set. So in MIPS, there will be an advantage. They're only going to score your 6 highest scoring measures, and you'll be and your lower scoring measures are going to set you up for an improvement bonus in years to come. So there will be, that's a solid strategy in the MIPS program. Again, I'll confirm that as we read deeper into the final rule, and when you join us for the webinar, I'll have a solid answer for that for you. Now we are a hospice, and struggling to find measures to report. Some of the measures that apply to our practice we are ineligible to report as we don't have office visits, so there is no volume. A common problem. So I'm dividing this into a couple of questions. One is, what is your advice when it is hard to find measures? Well, we process your Medicare claims through our measure analyzer, and we give you a complete list of measures you're eligible to report. And I think that's an important piece. It tells you where your eligibility is. Now, don't believe that PQRS or MIPS is just about ambulatory visits. There are plenty of facility codes or facility visit codes, not facility codes. Facility codes is charging for the bed in the hospital or the bed in the SNF or the hospice. But your visit codes, the professional codes that track to those visits, those do come through on the eligibility. So we can tell you from looking at your claims which measures you're eligible for and then guide you to that discussion. But just because you're eligible, you have the CPT and ICD codes that qualify a patient for a measure, doesn't mean that you should submit them, because you really should submit measures with meaning, measures that mean something to you that are within your scope of care. If you don't, you're not going to perform well in that measure, and there's really no reason to invest in a measure you don't care about. So you should be choosing those measures of meaning. If you don't have enough measures, we can help you use the measure applicability validation test to make sure that a small measure set is giving you a qualifying submission. And Medicare tells you when to use the MAV. It says use the MAV only if 9 measures in 3 domains is not appropriate or possible. It's not appropriate if the measure you're considering is not in your scope of practice. If you don't give flu shots, you shouldn't report on flu shots. And in a hospice, well, you might give flu shots. Probably not. You're certainly not going to be doing cancer screening. You're not, tons of measures that you're just not in your scope of care in hospice work. And possible, of course, that's an interesting word. I suppose if the data is not accessible to you, it's not possible. But it also gives you some freedom for judgment as to whether or not it's ethically appropriate for you to use the measure applicability validation test. All right, excuse me while we all take a deep breath. Okay, so Jennifer asks, under MIPS, when it comes to the eligibility requirement of billing more than $30,000 a year or provider care for at least 100 Medicare patients, is this a group calculation if you plan to report as a group and an individual EC calculation if you plan to report individually? And Jennifer, that's my understanding. And again, I may have more for you when I read when I get finally through all the pages of the final rule. But yes, it looks like you choose. And if you're reporting as a group, it's obviously going to be easier to hit that or harder to escape using the low volume standards. And a relatively large group, if you decide to report individually, would more easily all exclude based on the low volume standards. So that's interesting. It really argues that part of our algorithm should be looking at both of those as you submit your data to us. What if? How many of your providers exclude if you report individually versus how many of your providers exclude if you can you exclude as a group if you report as a group? And of course, you might not want to exclude. If you're in line to get an incentive, you may very well want to report as a group so you get above the low volume thresholds so you can get into the incentive range. So there's a very interesting set of strategies that are going to be uncovered in these in the MIPS program, and we plan to be ready to help you make those strategic decisions. Next question, we are a hospital-based pathology group with an independent anatomic lab. How will MIPS be any different than PQRS for us? And another related question, we are a hospital-based pathology group. Since we do not see any patients, how will MIPS and quality payment program be any different than reporting PQRS measures? Thank you for giving me two that I can answer with one. So I'm actually pulling all these together into one answer about radiologists and pathologists. So first let me say that all physicians with Medicare Part B billings are subject to MIPS. Expect some protections from ACI as a hospital-based provider, from cross-cutting measures have disappeared in MIPS. No longer a concern in the final rule, at least that's the initial read. And certainly not as a non-face-to-face provider. And you're getting some reduced exposure to clinical practice improvement activities. But quality reporting looks almost exactly the same. At least the dynamics of reporting look the same under MIPS as it did under PQRS. Now there are fewer there are no longer the cliffs to fall over. So it's not a pass-fail program anymore. So it's going to be easier for you to at least get up to avoid those total losses if you're having trouble reporting or you don't want to report. And of course, it looks like we've lost the measures groups, so we no longer have the ionizing radiation measures group. We didn't have anything for the pathologists. And of course, we are under the threat of all payer 90% reporting requirements. It looks like the reporting requirement has dropped to 50%, but it's still at all payer, and the pick your pace means that there's some very easy outs with very low reporting requirements, but also no limited ability to get into the incentive range. Episode costs do introduce the risk of cost accountability, but cost of care or resource use has been eliminated for the first year in this transitional year. So we've got a year off from that cost accountability. Now, under PQRS, there was a flavor in at least one of these questions about independent testing facilities. I don't know whether you're an independent testing facility or not. That has a certain legal status or setup requirements. So if you are an independent testing facility, either laboratory or radiology, they are excluded from PQRS. I haven't seen that in the proposed or final rule. It makes sense. It's there. They may not put it there, but still rule in that direction. So remains to be seen yet whether you have if you're an independent testing facility, whether you have a MIPS reporting requirement. So next question, what are the main differences between PQRS requirements and MIPS? Oh, here, I've got a question from John that says, with the pick your pace option available to all practices, which potentially reduces the amount of negative adjustments being given in the first year, does this limit the opportunity for practices who are ready to report for a full year to earn an incentive or have an advantage over its peers? Well, yes and no. I don't ever expect to see the windfall incentives that we're seeing in 2016. I think the dynamics that really everybody's in whether they want to or not, and I think, and particularly in the first year with the protections, there's going to be fewer penalties. In fact, there really is no excuse for you to be penalized. It's your fault if you get. Let me be harsh here. It's your fault if you get penalized in for your 2017 reporting. We can help you avoid. Medicare has given you so many ways out that there is a strategy for you to avoid the penalty. The only people we'll be collecting penalties from will be those who do nothing. And if you do nothing, it's going to be a 4% loss. Period. And that 4% is the pool, as you point out, John. It's the pool from which the incentive earners will collect. I suspect, what we Deloitte just came out with a survey that showed that 50% of providers aren't even aware of MIPS and MACRA. So you guys are already ahead of the game, and that 32% don't understand the first thing about it. They recognize the acronyms, but they don't understand anything. So 82% of providers are really in the dark about these programs. So I think we can count on a fair number of them not doing anything. We've learned that the most active time for signups, we get more new clients when the penalty letters go out or the penalties actually start getting received by the practice. That's what drives people's awareness more than these advanced warnings. So I think that'll happen in MIPS. So I think there will be money for you to collect some kind of an incentive from. Also, so Medicare's predictions for next year, they think that they'll collect about $200 million in penalties for the 2017 performance year, and they'll have that $200 million to distribute amongst on the incentive side, the positive adjustment side. They also are kicking another $500 million into the pot for the high performers. And they plan to set that at about the 70th percentile that you'll start earning out of that $500 million pot. So there's actually, that's a multiplier of 3.5 times what's collected from the negative adjustment that you can get in the incentive range. So it's good news. I think there's something to be earned. All right, so here's kind of a summary of the differences from PQRS to MIPS. The maximum penalty, when you combine the PQRS quality tiering and meaningful use programs together, you get a 9% total maximum penalty in 2016, again, depending on your practice size. MIPS year 1 is 4%, so automatically we have less to lose in MIPS. But over 4 years, it's projected to get up to 9 to restore that 9% loss. Meaningful use dramatically simplified as advancing care information under MIPS. The measure load drops from 9 measures in 3 domains to 6 measures. No more mention of domains. There is a requirement for an outcomes measure or a high priority measure if there isn't an outcomes measure. No further mention of any cross-cutting measures. Incentive penalty is a pass-fail system under PQRS and meaningful use for that matter. MIPS, the MIPS adjuster is a composite and continuous variable, so there's small improvements or small worsenings create small changes in your adjustment. You no longer have those big cliffs to drop over, which is great. I think that's a wonderful change. Incentive multipliers, there's been a windfall in quality tiering. There's still a windfall, as we said, 3.5 times the impact when you factor in the high performance bonus, but it's going to be less. There's not going to be that enormous windfall in MIPS that there was, 16 times times X in the 2016 payment year. Reporting requirements, 50% reporting rate on Medicare Part B. They were predicting 90% reporting rate on all payers. That's dropped, it looks like, to 50% reporting rate. Still on all payers. I still think that's a mistake. We'll see if we can get that eliminated by 2018. And it's also a quarter of the year. You're all in with just a 90-day reporting period. Now, I don't think that makes much difference if you're extracting your data from an EMR. I'd suggest you just continue to do a whole year data. But if you're abstracting charts, that's an enormous difference. So cutting to 50% reporting rate, a quarter of the year, of far fewer charts to pull, although, again, we still have the all-payer problem. The sampling option, you had the measures group where a 20 patient sample was all the reporting you needed to do. A web interface gives you a 248 patient sample. Now we only have the web interface option as a sampling option. And again, I'm going to continue to lobby for returning to the measures groups. Even with doubling that number of patients, a boon to people who don't have access to their EMR data. Eligible clinicians, anyone who bills Part B. In the first year, it's dramatically abbreviated. So all the ancillary providers that are included in PQRS are dropped. So the eligible count drops by about half automatically, and then when you exclude the low volume providers, that's another 32% that drop from the rolls. So there's a lot fewer who are actually eligible for MIPS than for the PQRS and the value-based modifier. And of course, resource use, adding episode measures is going to open up cost analysis for even the specialists, those of you who are free of cost analysis under value-based modifier. We'll see it when we finally get to episode measures, but again, there's no cost measures in 2017, in the first year of the program. There's a possibility they'll extend some of these breaks into the second year, but I'm expecting to see cost measures appear in 2018. I attended the last MGMA seminar in Houston, Texas regarding MIPS. They spent very little time on how to read and understand the QRUR reports. Any chance you can break down the report by category and explain if we are in the good range versus what we need to work on now? And that's way out of context for today's session. I can spend an hour on the QRUR report. Actually, you can get most of your data on that in 30 minutes, but we don't have the time today to do it. But we've scheduled a webinar. In fact, I think we've changed the date to the 25th. Go to this link, mingleanalytics.com/webinars, and register for the QRUR. I'll be showing you a de-identify QRUR. We'll walk through it. You'll have a chance to ask questions. We'll show you how to read it and what each of the pages, what each of the sections means. Remember, you have a 60-day window to ask for an informal review. That 60-day window is over November 30th. So you just have till the end of November to ask for informal review if there's any adverse findings. And an interesting thing about this, Charles just reminded us that the webinar is on the 25th, not the 26th, so the day before that. What was I saying? In years past, when Medicare made mistakes in applying negative adjustments, when it was their mistake, they tried to correct it and then recalculate. This year, they seem to be they've made a ton of mistakes. At least from our submissions are generally accurate. So when Medicare tells you you've got a negative adjustment coming to you, and we told you you didn't, what we're finding is Medicare is usually wrong. But they're pushing us to informal review instead of just curing the problem. So look, if we did the submission for you, there's a great chance that we were right and Medicare is just misapplying their rules. What we're finding is the help desk agrees with us. We say yes, but they don't correct it. What they say is submit your informal review. We'll help you with that. Be in touch. Operators are standing by. Can you speak to the benefits of submitting PQRS to a registry? Our practice has 5 EPs, all submitting 9 measures, but the cloud-based EHR charges for every report submission. Yeah, I think the best way to answer that is, again, getting back to Medicare's data about who's doing what. And this is a little redundant over what I showed you earlier, but here's on the left is a chart from Medicare's 2014 experience report showing that we're seeing a steady increase in the number of eligible providers, up to 1.3 million in the 2014 submission year. Of course, that's going to take a temporary but dramatic drop when we go into MIPS. And we're up to 62% participation. Now, on the right-hand side, it shows us what methods those people are participating in. And from the very beginning, claims has been the most common method. It was the first method that Medicare supported, and it's been head and shoulders above everything else, despite its very high failure rate. So, you know, I think claims has gotten such traction because everybody has the infrastructure to submit a claims measure. If you're submitting bills, you can submit a claims measure. So it looks free. It has the illusion of being free. But it's only free if you don't care about the results. It's got a high failure rate, and if you don't value your time, it takes time. It interrupts the flow of patients, I think, to do this very well. So correct. Now, what I see, and I've always been preaching the GPRO as the most cost-effective way, and that's finally getting the market penetration I think it should get. So it's now, in the 2014 year, it rocketed up to second place, a very close second, and those curves look like they're going to cross in the 2015 year. So I think GPRO registry remains the single best. Look how everything else trails that. And I think that's your colleagues voting with their feet about the best method. And I showed you we'll go back to that effectiveness level. GPRO registry, it gives across the vendor market, it shows GPRO registry to be about 85% effective. Now, again, a great vendor should be able to get that up to 100% or near 100, and we're at about a 4 sigma level of success there. Now, I was alerted to a couple questions, but I don't see any. What's that? Okay. And another reason why to consider registry reporting instead of EHR is a number. You get much more choice if you're having trouble finding measures, you're going to more likely find measures in the registry than anything else, as it shows here. And comparing registry to EHR, you know, there's 350,000 providers using any of the 3 methods of registry submission, only 50,000 using EHR. Combine the failure rates in the overall market, which again, I think overstates the failure rate in registry, understates the failure rate in EHR, but still the trend there is clear. 198 measures in registry, 63 in EHR. You can be flexible in your documentation workflows. The registry can cast a broader net if it needs to get more data. EHR doesn't tend to be able to do that. We can accommodate multiple data sources. Most EHRs don't play well with their competitors. But we can grab data from your practice management system from multiple EHRs, bring that all together into a single submission. Most good registries can do that for you. We accommodate the Medicare changes, even changes that are announced today. We've had them in our algorithms within an hour. I've never seen that kind of responsiveness in an EHR. So accommodating those last-minute surprises. And pricing, I can't tell you much about the pricing. That really is vendor specific. You said I have seen some EHRs that charge by the provider and by the measure. So it can get expensive and tedious. So a practice is performing in the 93rd percentile for the diabetes A1C measure. There's minimal room for improvement. They're already performing above the benchmark. Is this a measure they should submit in the quality performance category since they will likely to continue to perform above the benchmark? Is CMS calculating relative or actual improvement for scoring in the future years? Is this a measure they should continue to submit in the following years if it doesn't improve? And the answer is yes, this is a good measure to submit. So the fact that you're performing above average is, I think, the key. There is now. It's really going to take a sharp pencil and some mathematics to understand what the best strategy is for any particular group in any particular year. Because what you're referring to here is that Medicare is putting an infrastructure in place that you can get rewarded for improvement. But I don't think the improvement bonus is ever going to outstrip your ability to just perform extraordinarily well in a single measure, even if that's year after year after year. Now, some measures are topping out, so everyone's doing well, and you're not going to get as many points for those measures, so it would be better to abandon those and go to something where you can excel, where there's more spread. So tons of questions about strategy that will help you we'll need to help guide you through case by case. But I would certainly not abandon your diabetes A1C measure. All your good performing measures are going to still be good. What you'll want to do in MIPS is work on more than 6 measures. You're going to want to have at least 12, maybe even 18 measures in the queue, and then every year be able to choose the 6 measures that are going to set you up for the best scoring. And that might be your best. That might include a measure that you want to collect the improvement bonus on. And finally, can you please clarify for MIPS that for the quality program we're reporting on at least 50% of denominator compliant patients for all payers? And yes, that's my understanding as well. I have not yet, I'm sad to say, gotten to page 481, but that is my understanding at this point of the MIPS rule, that it's 50% for all payers for 90 days. So there is one more caveat. So that gets you down to what, 12.5% of your denominator compliant patients, possibly. And all right, so it's the usual time. It's 12:59. You've blown almost a perfectly good hour with us, and I know some of you have to get back to some real work. So feel free to go back. This has been fun for me. I hope I was instructive and it was fun for you. There are some more questions, and like usual, we'll stay on the line and answer questions beyond the top of the hour. With your permission to go on your way and get real work done, I will now start going through the questions that are newly applied and see what fun we can have there. So Jane asks, should we stay away from the BMI and tobacco measures? And I'd say no. Again, with okay. Oh, I'm told I'd better read both questions at once. So, and this next question in this, I was told that we should stay away from measures that are easily attainable and try to use measures that show more improvement. Well, again, 2 different strategies there, and maybe 2 things to consider. One is the concept of topped-out measures, and a topped-out measure is a measure that everyone's performing extremely well in. And Medicare has decided, and I approve of this, that they had initially thought that they would just jettison any measures that are topped out. That is where a standard deviation above average gets you well above 100%. So you really can't excel on those measures. But the downside of that is that many of our specialists who are having difficulty finding a full measure set are relying on those measures. So they decided to keep them, and they've decided to again, I need to see this in the final rule. It's in the proposed rule. I don't see any evidence that it's changed, but we will see. But they've decided to reduce the number of total points you can get for those. But because the other measures are so difficult to do well in, I would not discount them. Again, those things that you've always done well in, I would keep in your measure set. And when it comes time to choose the 6 measures that we're going to submit for you for this year, we want to look at your best possible score. And that could be a measure that you've seen improvement in, you get a bonus point for the improvement level, as well as the score for the level of performance you've achieved. But it might be that a measure that you can't earn any more than 7.5 points on still might be one of the best measures to submit and put you well into the incentive range. So by no means abandon those measures. If you're doing well in them, keeping them in your back pocket, but we may not submit them in any particular year. That might not be a measure that we submit, but you're going to have some extra measures in the queue. Are we to the end of our questions at the moment? Let's see, what is this? With the pick your pace option available to all practices which potentially do. What's that? You answered that already. Oh, I answered that one. All right. I think we're good. I can't see anything. All right, great. So I've answered all your questions. You've been a wonderful audience. Again, you haven't thrown anything at me, not that has reached my perch here, second floor above Market Square in South Paris, Maine. So thanks again, and tune in for a QRUR session in a week or so, and stay tuned. About 2 weeks away from a thorough review of the final rule. Ta-ta for now.